Hello and welcome to the UB Medicine Podcast. I'm Dr. Allison Brashear, the Dean of the Jacobs School of Medicine and Biomedical Sciences and Vice President for Health Sciences at the University at Buffalo. Today we're talking about a profound and timely topic, the science of aging. And today we'll learn about what we know about Alzheimer's disease and other memory disorders that really impact millions of individuals and their families. What we know is as people live longer, aging science has become one of the most important frontiers in medicine. I know as a neurologist, we talk about healthy aging and what we can do for people's brains to make sure they age in a healthy way. Our faculty at UB are advancing breakthroughs in prevention, diagnosis, and care, and strengthening the support systems for patients across Western New York. So, joining me today are two leaders helping move the field forward. Ralph Benedict is a distinguished professor of neurology, director of the neuropsychology services at UBMD Neurology, and a board-certified clinical neuropsychologist who's internationally recognized for his work in cognitive aging. And Dr. Kinga Segedi is associate professor of neurology, founding director of the UB Alzheimer's Disease and Memory Disorders Center, and director of Translational Genomics Research Laboratory. Ralph and Kinga, welcome, and it's so wonderful to have two neurologists here to talk about Alzheimer's disease and aging, and hopefully to give us all some tips about healthy aging. So before we dive into the science, people who are listening are probably worried about a parent or partner that may have aging-related disorder, Alzheimer's disease. So what does that really look like, and what should families look out for?
Well, we should pardon ourselves for being a little slow as we get older. The processing speed is sort of the hallmark of normal aging. And we should also recognize that it's normal to occasionally lose things, walk into a room, not know why I walked there. These are common issues that arise with aging, but they can become a problem if they are more frequent and more severe. When we get into a situation where the word-finding difficulty is interfering with conversations, people will lose their way in a conversation. That's a sign of some major problem. To have a lack of memory of recent events, especially things that the person was really involved in and is something they're interested in. Also, problems with getting lost as a sign of real difficulty.
Like driving, people who get lost in driving
exactly.
And find themselves not. So Kinga, what do people, when families come to your office, are there other things that they kind of worry about, and when they bring a family member perhaps, or themselves?
So we are very different. Everybody is different, and people and families have very different sensors when they come to see the doctor. We have patients who come in and we can tell them that you are just getting older. It is just a subjective memory loss. And we have families who come in moderate stage dementia because that's when they recognize that my loved one cannot pay the bills, cannot manage their meds. They need 24/7 care, and that's the first time when they come. So it's a very broad spectrum. And following up on Dr. Benedict's comment, at one point it becomes very clear that there's something wrong. But now with the new treatments, and as the field is moving forward, and we know that Alzheimer's disease is not going to be a reversible disease because the brain is not going to regenerate. We have to keep and use what we have. We are trying to shift the diagnosis as early as possible. So I think that even in the clinic it shifted, that we used to have a lot of patients who come in moderate stage dementia, clear Alzheimer's. We have a lot more who come in with amnestic mild cognitive impairment, the pre-state for Alzheimer's. And those are the ones where we can make the biggest difference in treatment.
I will speak from personal experience. So I'm a neurologist, and my mother-in-law passed away from Alzheimer's disease. And she was still a teacher, and we noticed she planned a great big event. I think it was maybe Easter breakfast or something. And then when we went to go figure out where to pick up the items that she had ordered, she had no idea. And so, these are really life-changing experiences for families and the patient themselves. And so the fact that we have treatment, she received one of the earliest pills to go to market that I think no one uses anymore. But it's really, really important that we have new treatments. And so things have changed dramatically in the course of my career. And I'm so grateful for the work that you've done and the many others, but the both of you. So could you say a little bit more about the new treatments that are available? Because I think those are some things that we all have a lot of questions about, and the importance of getting a thorough evaluation to make sure it's not something simple like normal pressure hydrocephalus or thyroid or any number of other things.
We have a stereotype workup, because basically when somebody comes with a cognitive problem, there are certain things that we have to make sure they don't have, and everybody deserves a scan according to the American Academy of Neurology. We don't want to make a diagnosis perhaps for a small stroke that was silent and just affects memory, or meningioma that presses on the cortex, which is responsible for speech. So we have this very circumscribed typical workup. We do blood work for correctable causes and modifiable risk factors. And these are things that if we can fix them, maybe people can get better, or at least we are slowing progression. And when we get older, in the oldest old, we have different symptoms. So memory loss can be a symptom of something that is absolutely not related to the brain function. It's more like a medical illness, and we can actually fix it. It's the same in babies. They can have a seizure, and it could be meningitis. It's kind of the same at the other end of the spectrum. And the MRI is very useful, mainly to rule out things, but now it's becoming more sensitive as a biomarker, and we sometimes see the local changes in the brain, shrinkage, which suggests that there's Alzheimer's disease. And then because we are trying to move the diagnosis as early as possible, and we don't want to wait until it's obvious, we heavily rely on our neuropsychologist colleagues. Actually, we set up the protocol with Dr. Benedict. When I first came to UB, we decided that we need an Alzheimer's center. And he guided how we set up that protocol to be brief enough, but thorough enough to get all the answers that we need for a good dementia differential diagnosis. So we do these 3 tests. And then when patients come back, many times, most of the time, we will have a good idea what they have. We can tell them what the disease is and what stage they are at. But sometimes we don't know yet. Sometimes people don't read the textbook and they are in between. Then we have other tools like PET scans specific for Alzheimer's and things like that. For the treatment, for the new treatments, for the monoclonal antibodies, these are IV medications that go into the vein, and then the antibody grabs the bad protein in the brain and really clears it out. For that, everybody needs to have a proven scan or spinal fluid study that shows that there is amyloid in the brain, because that's what we are targeting. If it's not there, we shouldn't treat it. So we do that here at UB. We actually were part of the donanemab clinical trial. So we have now 4 years of experience of doing this. And it sounds scary, when you hear about it, that a lot of side effects, brain swelling and bleeding. And whenever something new comes in, I think there's always a pendulum. So the first notification that there's treatment for Alzheimer's, people started to call us and everybody wanted a treatment. Then the first side effects came out, then everybody said, no, not that drug, I can have a brain bleed and die. So we are learning together with the patients and how to present it to them. But basically, this is what I call it's managed risk. Because we know it might happen, but we have tools to prevent it. And those are the MRIs every month that we try to detect all those changes before symptoms start.
So let's, you used a term biomarker, and all of these things are biomarkers to detect actually whether someone has specific Alzheimer's disease. You also mentioned clinical trials. Could you just reflect a little bit about the importance of clinical trials? My mother-in-law participated in several clinical trials and has subsequently passed away. But that is a key piece on how you advance research. You would not have these new drugs that you just described without clinical trials.
Yeah, there's no drug without clinical trial because we have to prove that it's efficacious, that there's a benefit, and we have to know how much harm we are doing because the benefit risk ratio should be favorable. So we won't know until we run the clinical trials. And that's usually the answer even for supplements. People ask me, should I take this supplement? It says super smart brain and things like that. If it was not tested, you don't know if it does anything good and it may just harm you.
Yeah, that's an incredibly important point. I have to ask you, people are going to want to know, is there a blood test for Alzheimer's disease?
So there is a blood test that was FDA approved. It's still a screening tool. So when you do this blood test, it increases the chance that you have Alzheimer's if it's positive. But it's set in a way that there are still false positives. And some people who have Alzheimer's may be negative on the test. So even if you have the blood test, you still need to do the PET scan if you want to go for the monoclonal antibody treatments, for the specific treatments. And honestly, New York State has its own issues with the blood test. It was extremely difficult for New York State to get it through the system. And even now, insurances don't cover it.
And it's just like ApoE, ApoE is another biomarker, a genetic biomarker. And, it means you're at increased risk if you have a certain profile, but it's not 100%. So I guess that's part of the role of neuropsychology and the teamwork that you have to figure out who potentially has Alzheimer's and then who are those people that need to be treated. We have really been at the forefront, the work of you and the clinic, about how to diagnose and change the course of the patients in Western New York. Ralph, can you walk us through kind of a modern cognitive assessment and how perhaps we can coach and counsel patients about lifestyle alterations?
Sure. Well, in a neuropsychological evaluation, we cover core domains of mental status, like expressive language, visual spatial processing, learning new information, and also remembering that information over a time period of, say, a half an hour in our clinic, ability to attend, process information quickly, and then what we call executive function, which is the ability to think abstractly and conceptually. But it's more than that because we also, there's a psychological part of neuropsychological evaluation. Many people that have neurological disease affecting the brain also have changes in personality and develop psychiatric symptoms. It can be complicated because that helps us with the diagnosis when we quantify those symptoms and get a good clinical appreciation of what is going on. But those are also comorbidities that can interfere with the testing. So if somebody comes into the clinic and they're in a major depressive episode, it's probably not the best time to do that testing because major depression causes memory problems. So it can be a complex situation.
And the major depression, particularly in the older patients, may show up as memory problems as differently than it may show up in a 20-year-old.
Yes, and we can figure that out in the clinic if this is major depression versus early dementia. But people often are confused about that.
So there's also some connection between cardiovascular health and your brain health. And that's an evolving field. And then people also say, what's one thing I could do? There's a recent study out called the U.S. Pointer Study, for example, that my colleagues at Wake Forest helped lead. Tell us a little bit about that and the importance of going to the gym, as we say.
The Pointer Study was really a great study. I was there at the top line data release at the AIC. So it was a study where they took individuals who were getting older. They were not affected by Alzheimer's. They were not affected by dementia. And they told them what they are supposed to do. And then some people were just told what they are supposed to do, and some people had coaches who helped them really be stringent about doing whatever they were supposed to do. And, just a very simplistic way to say it, basically people who were regularly doing what they were supposed to do got 2 years younger over 3 years compared to the other group. So it really does help. And there were previous studies that showed that physical, mental exercise, structured days, socialization, all of these will even help slow progression of dementia. And we see it all the time in the clinic. I have I have gentlemen who swim every day, and their course, their trajectory of decline is very different than when you are just sitting in front of the TV. So the things that you can do for yourself, and I always tell my patients, because that's where you are in power, because everything else is just happening to you. You can eat well, and the MIND diet specifically is a good diet.
It's what diet?
MIND diet. It's Mediterranean with a little upgrade to be cardiovascular healthy. I read it in the car to my husband, and he said, well, I can do that. So it's really good.
A little olive oil, less salt.
Lots of olive oil.
Lots of olive oil. Terrific.
Swimming olive oil, yeah. So, the MIND diet, physical exercise, the more different things you do, the better. So it's not like you get on the treadmill and just walk, because what you want to do, you want to stimulate your brain cells, because brain cells are hard workers like German shepherds. They want to work. And if you give them enough input, enough stimulation, then they are healthier and they live longer. If you deprive them from the stimulation, they die. So that's why we have to correct hearing loss and visual loss with glasses, because all that helps. Actually, there was a study where they used diffusers overnight with different smells, and even that helped maintain cognitive health. So all the senses you want to stimulate, physical, mental exercise, the more different areas of the brain you are activating, the better for you. Socialization is extremely important. And that's basically what you can do for yourself.
So I'm going to remember that brain cells are like German shepherds. I got it. That's a terrific analogy. And they want to work. So can we talk a little bit about some other maybe drug discoveries, or we mentioned a little bit about clinical trials. But what do you think the future is going to be? I mean, I think every time we turn on the TV, we see an ad for some of these things. What do you think the future is going to be? Ralph, you see patients all the time, both of you. What do you predict for the next 5 years?
I predict a lot more emphasis on these interventions like we heard about from the Pointer study. And one thing that Dr. Zaghetti didn't mention was cognitive training was a huge aspect of that study. There's a lot of misinformation out about cognitive games you can play on your iPhone or your computer, and we need to learn a lot more about what really works and what doesn't work so that we can advise people better.
Great point. Crosswords are not going to be it unless you do it on the treadmill and do something different every day. So Kinga, what do you think about the future in the next 5 to 10 years?
So I think that the monoclonal antibody treatment is not the magic wand. It's not a cure, but the field really needed this step, that we were successful of finding something that works. There's a lot more to do. We have to understand the disease mechanism a lot more. We have to understand how Alzheimer's is different in different people, I think. Even though the GWAS studies didn't pin specific genes, but it was it's just one way at looking at the genome. So I think there's other factors like human genetic background that we are totally ignoring. There are different types of Alzheimer's, and once we know who has what type, we're going to have a lot more success with treatments. There's some tau targeting strategies that are emerging. A lot of neuronal receptors that are emerging as well. Again, based on the fact that if you stimulate the receptor, the nerve cell is happier because it's working harder. It's going to probably lead to two options. One, it's going to be really just such a multi-process Alzheimer's disease that we're going to need like a combination therapy, or we're going to find those subgroups that benefit from one specific driving mechanism treated, and then, we will have maybe a genetic marker that's going to say that for this patient, this medicine is the most efficacious, and for that patient, that medicine is the most efficacious.
So we need to change kind of the myth that you can't do anything about it. We need to make sure that people get to the doctor right early so that they can get evaluated for reversible causes, but also participate in clinical trials. And for families, it sounds like you want them to bring them into the clinic soon, and so that they can be involved in research and get the most cutting-edge therapies. And what else would you advise families or children whose parents maybe are having some memory problems? What would be the one thing you'd want them to do?
One thing that comes to mind is that an advantage of our multidisciplinary clinic we have here is that we do involve family, and that through assessing how the family is working as well as the patient, we can help with these preventative activities and also prevent social problems that may develop as the person is beginning to have cognitive problems.
That's an excellent point. So I'm going to take this to both of you, but Kinga, will start with you. What is one takeaway that you hope for the future of the brain health of individuals that live in Western New York?
Well, do your pointer study recommendations because that's in your power. And, be open to get tested, because I think that's another big problem, that people are so afraid of the diagnosis that they just keep delaying it. But I always tell the patients, we can just keep you as good as you are for as long as possible. We can't make you better. So earlier you come in, the better you are, we can keep you in that stage, and maybe sometimes for years. So I think that's my takeaway.
Ralph, what's your takeaway? What do you want people to remember?
Well, the Pointer study recommended 3 things: the MIND diet, or meeting with a dietitian to make sure you do that correctly, the cognitive training, which we talked about, and also meeting regularly with your physician so that you avoid hypertension, hyperlipidemia, and other cardiovascular risk factors that can contribute to dementia. So staying on that 100% is extremely important.
So your body health means your brain's going to be healthier regardless if you have Alzheimer's disease or not, right? And that's a really important point. I just want to thank you both for your participation. This has been a conversation that's tremendously important to our community. It's tremendously important to patients and families, and we're so glad that the two of you have the multidisciplinary clinic and have worked so long together, and that you're here at UB. I also want to thank our listeners for joining us. I'm Dr. Allison Brashear, and this is the UB Medicine Podcast. We look forward to more discussions about innovation, discovery, and the future of health in Western New York.